I am Dr. Claire Vega, and I want you to think about the last time you sat on the edge of your bed and noticed something strange happening in your feet. A tingling sensation that felt like walking across crushed glass. Or the opposite, a numbness so complete you could not feel the floor beneath you at all. That sensation often begins in the toes and creeps upward toward the ankles over months and years. You mentioned it to your doctor. They typed a diagnosis into your file without looking up from the screen. They told you that diabetic neuropathy is simply what happens when high blood sugar damages nerve endings over time. That explanation leaves out the part of the story that matters most. Elevated blood sugar is not the only mechanism destroying the nerves in your legs and feet. The medication prescribed to control that blood sugar is simultaneously starving your nervous system of the exact nutrient it needs to survive. I am going to walk you through exactly how metformin operates inside your digestive tract, because this mechanism is rarely explained to patients, despite being well documented in the clinical literature for over 2 decades. Every nerve in your legs and feet is wrapped in a protective coating called myelin. This coating functions the same way the rubber insulation around an electrical wire functions, keeping the signal contained and intact as it travels toward your brain. Maintaining that coating requires a continuous supply of vitamin B12. Without adequate B12, the insulation begins to break down. The exposed nerve fiber misfires. You experience the burning sensation as a direct result of that electrical short circuit, and eventually, the nerve fiber dies entirely, leaving permanent numbness in its place. Metformin interferes with a specific calcium-dependent absorption pathway located in your lower small intestine. This pathway is the primary route through which your body absorbs dietary vitamin B12. When metformin blocks this pathway, the vitamin B12 in your food passes through your digestive system without ever being absorbed into your bloodstream, regardless of how much B12-rich food you consume. This is not a rare or unusual side effect. Published research indicates that between 20 and 30% of patients on long-term metformin therapy develop a clinically significant B12 deficiency as a direct consequence of this absorption block. Your physician has access to this same research. The structural reality of a 7-minute appointment rarely allows time to explain intestinal biochemistry, so the prescription is renewed and the conversation moves forward without it. You might assume your annual blood work would catch this deficiency before it became a problem. Your lab report includes a line item for vitamin B12, and the number typically falls within the normal reference range. That standard test measures something different from what actually matters for your nerve health. The conventional serum B12 test measures the total quantity of B12 circulating in your bloodstream, including a substantial portion that is bound to proteins and biologically inactive at the cellular level. It does not measure how much active B12 is actually reaching and being utilized by your nerve cells. A patient can show a normal total serum B12 level while experiencing a severe functional deficiency at the cellular level where the actual repair work needs to happen. This distinction is well established in clinical endocrinology. The more accurate diagnostic markers are called methylmalonic acid and homocysteine, and elevated levels of either compound indicate a true functional B12 deficiency regardless of what the standard serum test shows. These specialized tests are ordered far less frequently, in part because they carry a higher cost and require a physician to specifically request them rather than including them in a routine panel. I want to walk you through what typically happens next in this cycle, because the pattern repeats with remarkable consistency. The burning sensation in your feet intensifies. Your balance becomes less reliable, particularly on stairs or uneven surfaces. You return to the clinic seeking relief. Rather than investigating the underlying B12 pathway, the standard response is to prescribe a nerve pain medication such as gabapentin or pregabalin. These medications do not repair the damaged myelin coating or address the underlying deficiency. They work by dampening nerve signal transmission to your brain, which reduces the sensation of pain without addressing why the nerve is malfunctioning in the first place. Common side effects include significant fatigue, cognitive fog, and dizziness upon standing, all of which can further compromise the balance and mobility that were already declining. The result is a sequence in which one medication contributes to nerve deterioration, while a second medication is added to manage the resulting pain, often without the underlying cause ever being formally investigated. Let me tell you about Arthur. Arthur is 68 years old. He took his prescribed metformin consistently for 6 years to manage his type 2 diabetes. Over the final 2 years of that period, he developed progressively severe burning pain in both feet. His physician diagnosed diabetic neuropathy and prescribed gabapentin to manage the symptoms. The gabapentin produced significant sedation and contributed to a 15-pound weight gain over several months. The combination of sedation and pre-existing balance issues led to a fall in his kitchen that fractured his wrist. When Arthur came to me, we ordered the specialized methylmalonic acid and homocysteine testing rather than relying on his previous normal serum B12 results. The specialized markers revealed a significant functional deficiency at the cellular level that the standard test had completely missed. We did not discontinue his metformin, since managing his blood sugar remained essential. Instead, we introduced a high-absorption form of B12 delivered in a way that bypassed the blocked intestinal pathway entirely. Within 8 weeks, the burning sensation in his feet had substantially decreased. His balance improved enough that he was able to discontinue the gabapentin under his physician's supervision. Arthur's nerves were not dying from an inevitable consequence of diabetes. They were responding to a correctable deficiency that the standard testing protocol had never identified. Here is the specific protocol to address this with your own physician. You are going to schedule an appointment specifically to discuss this concern, rather than raising it briefly at the end of a routine visit. When you sit down with your doctor, you will request the methylmalonic acid test and the homocysteine test by name. You will explain that you are asking for these specific markers because the standard serum B12 test does not reliably detect a functional deficiency that can develop with long-term metformin use. If your physician indicates that the standard test is sufficient, you can ask them to document that response in your medical record, along with their clinical reasoning. This is a reasonable request that any physician should be willing to accommodate, and it often prompts a more thorough review of the request rather than a reflexive dismissal. If the specialized testing confirms a deficiency, the form of B12 matters significantly for how effectively it can be absorbed. The inexpensive form commonly found in standard drugstore supplements is called cyanocobalamin, a synthetic compound that requires several conversion steps in the body before it becomes biologically active. Aging bodies frequently struggle to complete this conversion efficiently. A more readily usable form is called methylcobalamin, particularly when taken in a sublingual preparation that dissolves under the tongue. This delivery method allows the compound to absorb directly into the capillaries of the mouth, bypassing the digestive tract entirely and avoiding the absorption pathway that metformin has compromised. I want to be direct about one important point. You should not discontinue metformin on your own in response to this information. Stopping a prescribed diabetes medication without a coordinated medical plan can result in dangerous blood sugar elevation, which carries its own significant health risks. The appropriate approach is to continue your prescribed diabetes management while working with your physician to address the B12 pathway separately, using accurate testing and an absorption method that does not depend on the intestinal pathway metformin affects. You have spent years managing your diabetes carefully and following the guidance you were given. The nerve symptoms you may be experiencing are not necessarily an unavoidable consequence of that diligence. They may reflect a specific correctable deficiency that standard testing protocols are not designed to catch. Bring this information to your next appointment. Ask for the specific tests by name. Discuss the appropriate form of supplementation if a deficiency is confirmed. Continue your diabetes management under your physician's guidance throughout this process. I am Dr. Claire Vega. I am reading the clinical research that exists in the published literature and translating it into language you can actually use at your next appointment. Hit that subscribe button right now. because my next video examines the conventional advice to minimize dietary sodium and looks closely at what the more recent research actually shows about sodium needs in older adults, particularly those managing certain kidney and cardiovascular conditions. The picture is more nuanced than the blanket advice you have likely received, and you deserve to understand the full context before your next conversation about your diet. I am Dr. Claire Vega. I will see you in the next video. I